MedCram.
Welcome to another MedCram lecture. In our last lecture, we talked about measles or rubeola, and we talked about the different types of infections that it could cause and also signs of the infection with the different stages, including the incubation period, the prodrome period, the exanthem period, and then the recovery phase. We're going to talk about the diagnosis and the treatment of measles. So I'd like to refer you back to the first video to make sure that the clinical signs are being obtained. Specifically, you want to remember the 3 C's, which is cough, conjunctivitis, and coryza. Coryza, remember, is just basically rhinitis. It's a runny nose, okay? And then, of course, you definitely want to know about koplik spots. These are inside the buccal mucosa, and if you want to think about a very red erythematous background, so if you're looking inside the buccal mucosa, it's going to be red, and then if you were to look on there, think about grains of salt on a very red, hot background, and this is usually around the molar. So we know kind of the clinical scenario. What about the diagnostic scenario? What is it going to look like on lab? So, it's very non-specific, but you'll see platelets, low. You'll see low WBCs occasionally. Specifically, you'll see low T cells. And this can sometimes be a problem in patients who are immunocompromised. They can sometimes get flares of, for instance, tuberculosis or other T cell mediated diseases that measles would cause because they reduce the T cells. Sometimes on a chest Xray, you might see a pneumonitis. So inflammation of the lungs. However, the thing that you probably would see, and this is the way that we make the diagnosis, is antibodies. So there are circulating antibodies to measles. One is called the IgM, and the other one is called the IgG. Now, if you remember from immunology, IgM is the type of antibody that comes out immediately. They're sort of the first responders. If we see an IgM that's elevated, then we know that this is an acute infection. Then the IgG comes out. This is the antibody that remembers. So if we were to give a vaccine to somebody, we would expect after years and years of that vaccine to be circulating IgG antibodies, but not IgM antibodies. If we saw IgM antibodies for any kind of infection, that would be a telltale sign that this patient had a recent infection. So to give you an example, if we saw a herpes simplex virus, IgM and IgG, if both were elevated, that would indicate an acute infection. If the IgM was not elevated, but the IgG was, that would indicate a past infection that is no longer current. So how does it work for measles? The way we detect whether or not you've got a measles infection is by checking not to see if the virus is present. They sometimes do this in epidemiological studies, but to actually see if your body's immune system has a response to the virus. Now, when the rash comes on, within 1 to 2 days, there will be a rise in the IgM, and it will rapidly go down within a month. And this is an IgM that is specific for measles. The other name is rubeola. Now, there's 2 ways of doing this, and you might run into this. This is very specific here. There's something called the IgM capture ELISA. And there's another type called the IgM indirect ELISA. The key here is the word capture versus indirect. The capture technique, they're both actually very fast. Capture usually can be done in about 2.5 hours, whereas the indirect usually takes about 3.5 hours. They're both very sensitive, specific, and have good negative and positive predictive values. The key, however, with the indirect ELISA is that you have to remove the IgG from the assay, whereas you don't need to do that in the IgM. And so there is this added step that could complicate things and give you inaccurate results. So the one that's probably superior is the IgM capture ELISA. However, the one that's used probably most often is the indirect ELISA. Just be aware of false positive results if you use the indirect ELISA. There are two other techniques that can be used. One is called the Plaque reduction neutralization test. This one can take up to 10 days. Probably not the best, and it's not an easy test to do. The other one is a hemagglutination inhibition test, and it requires 2 samples, both acute and convalescent. This can take up to 2 days after the receipt of the convalescent serum. So if you want a rapid, I would recommend the ELISA. Okay, so now that you've made the diagnosis, how do we treat these people? Well, it's a virus, and so as a result of that, supportive treatment. This means if they're dry, you give them fluids. If they're having fever, you give them antipyretics. So fluids, antipyretics, and just treatment of bacterial infections. So they may need antibiotics because they have superimposed bacterial infections, for instance, like pneumonia or a bronchitis. The second thing that's very interesting that they've found is vitamin A. Now, they don't know exactly why this works, but they've seen it especially in developing countries where vitamin A deficiency is higher than it is in developed countries. So giving vitamin A may be helpful, and there's a different dosing for infants or children. The other thing that is not really FDA approved or hasn't really undergone rigorous prospective controlled studies is Ribavirin. They noticed that if it was given intravenously early on, that patients had a larger chance of surviving, but this was in a very small population. So the question is on vitamin A. The question is on Ribavirin. We're not sure. The key, however, is supportive care. Thanks for joining us.